Next, it is my pleasure to introduce to you Dr. Roni Tamari from Memorial Sloan Kettering Cancer Center across the street, who will be presenting or demystifying the process of a hematopoietic stem cell transplant for us. Dr. Tamari.
Hi, good afternoon, everyone. So my name is Roni Tamari, and I'm an attending on the... Hi, better? Okay, hi, good afternoon. My name is Roni Tamari, and I'm an attending on the adult bone marrow transplant service across the street at Memorial Sloan Kettering. And I'm very happy to meet you all today, and I want to thank the organizer for inviting me. And yes, the title of my talk was to demystify bone marrow transplant, and that gave me a little bit of anxiety. So I kept my title a little bit simpler. Just we will start talking about allogeneic stem cell transplant in myelofibrosis, and then we can think together if I demystified it or not, or we can address more questions to try to do that. So I have no conflict of interest to disclose. What I would like to talk about is treatment options with regard to transplant and non-transplant options, the transplant triad, and timing of transplant. So to start with a little bit treatment of options, I'm sure this was discussed today already, and you all know that the therapeutic landscape of myelofibrosis has changed dramatically in the past decade. Started with the approval of ruxolitinib in 2011, and then approval of fedratinib in 2019, and then pacritinib that was approved in 2022 for intermediate and high-risk myelofibrosis, and particularly in the context of severe thrombocytopenia. If we do a quick clinicaltrials.gov search, we see that I entered myelofibrosis, I entered active accruing clinical trials. We see that there is a good number of studies. There are 22 just in the New York area and more than 50 over the country. However, we still consider allogeneic stem cell transplant as the only curative treatment for this disease. Maybe microbiome and Jacophy will do it, but for now, this is the only curative treatment. And as you can see here for a report from the European Bone Marrow Transplant Registry, the number of transplant is increasing over time. You can see in the past 15 years, we went from somewhere around 150 a year to somewhere around 500 a year. And you can also see on the lower part how the older patients are being referred and undergoing transplant. And we can see very similar trends here in the United States, where the green line reflect, unfortunately, it's combined myelodysplastic syndrome and myeloproliferative neoplasm, but certainly both diseases are being referred, more and more transplant are being done for myeloproliferative neoplasms. The encouraging information is that transplant outcomes are improving over time. So if we look at the early 2000s, we can see that the overall survival at 1 year was around 60%, and going to more recent years, 2016 to 2018, we're discussing overall survival of a little bit over 70%. So what do I mean when I talk about the transplant triad? So every time I see a patient for discussion about transplant, I say we need to have three factors here that we really need to address, and they're equally important. It's the patient, it's the disease, and it's the graft. So talking about patient-related factors. Anytime we assess patient for transplant, obviously we need to look very carefully to all of their organ function, and we send patients for a very detailed evaluation of their heart function, their lungs, kidneys, etc. And with that, we build our hematopoietic stem cell comorbidity index that helps us to assess particular risk for complications with transplant. However, there are some things that are very unique to patients with myelofibrosis undergoing transplant that I want to highlight. So one of them is iron overload. We know that iron overload is associated with decreased overall survival after transplant, mostly due to increased risk of non-relapse mortality. Why is that so relevant and important for patients with myelofibrosis? Because many times patients are being referred to us after years of being transfused and being dependent on red blood cells. And that actually builds also into the severity of the disease, which we'll talk about in a second. Beyond that, the more transfusion patients get, the higher the risk that they will start develop antibodies. And with antibodies, HLA antibodies, they are at higher risk of actually rejecting the graft. So really coming to transplant, not after years of transfusions and without iron overload, is very important for us. The data is still very conflicting about trying to reduce iron overload pre-transplant. Many times, unfortunately, when patients are already transfusion dependent, our goal is to try to proceed to transplant without delaying. And the treatment that are available currently for iron chelation and reducing iron are actually not as effective in terms of timing-wise. It takes time to use this medication and reduce iron overload. Another thing that is very specific for patients with myelofibrosis is the enlarged spleen. And again, enlarged spleen has been associated with poor and delayed engraftment after transplant, as well as increased risk of non-relapse mortality. Another question that has been in the literature for years, should a large spleen be removed prior to transplant by surgery or not? What the data is clear about, that patients who had splenectomy, removal of their spleen prior to transplant, have better engraftment. They have shorter time to engraftment. However, we need to remember that this is a surgical intervention, and when patients are with a very large spleen and advanced stage of myelofibrosis, this is not trivial to take them to transplant. Certainly, the JAK inhibitor have been very useful in that sense, and getting the spleen smaller prior to transplant and improving outcomes in that sense. So disease-related factors. I'm sure you heard a lot this morning already about the different prognostic systems that are available for us, whether it's the IPSS that started years ago, followed by the dynamic IPSS, and then the dynamic IPSS plus. And the core of that is really actually the clinical factors, is the anemia, the white blood cells, circulating blast, and constitutional symptoms. But you can see that as we move forward and we are trying to refine our prognostic system, we add to that. So the DIPSS adds to the IPSS in the sense that severe anemia is considered one of the most important factors. And then we look into the DIPSS plus, and also looking at actually transfusion dependence, not only the level of the anemia. In the past couple of years, checking for mutations in the context of myelofibrosis actually helped us very much also in terms of understanding better the prognosis of the disease. And what this figure shows is that when we used information about molecular mutations, we actually were able to stratify better patients. So patients that were, let's say, considered low risk, but they were found to have certain mutations, they would go into higher risk category when we add the information about the mutation, and that's what the MIPS and the MIP70 added in that context. Now, how does all of that help us when we come to transplant? Because when we come to transplant, it's not only about the disease. We actually just spoke about the graft comes into that and the patient. But we still see that when we apply the DIPS to patients who underwent transplant, it's still predictive of outcomes, where the patients with more advanced disease by the DIPSS are doing worse. They have worse overall survival, higher risk of disease recurrence, and also worse survival not because the disease comes back, but because of transplant-related complication, or what we call non-relapse mortality. We wanted to look at what happens when we actually include information about molecular mutation. And these are two studies. One of them was done by us at MSK in collaboration with our colleague at Mount Sinai. And both of these studies were limited with relatively small number of patients. Each one of them had about 100 patients. And what these studies shows is actually that high-risk molecular mutations did not predict for transplant outcomes, but specific mutations were associated with worse outcome, particularly UTAF1, DNMT3A, and CBL. However, because the cohorts were relatively small and the number of events were small, we were really not satisfied with these small numbers of patients. And with that, we went to the MPN Research Foundation and asked them to assist us with creating a larger cohort. And with that, we created what we call the NAMTO, or the North American Myelofibrosis Transplant Outcomes, where our objective was to try to increase our cohort to have much larger number of patients, and again, to study the clinical effect and the molecular effect on transplant outcomes. So the primary objective of that was to determine if clinical factors and or genomic alteration impact the outcomes of myelofibrosis patients undergoing transplant. As of now, we were able to work with 11 centers, and we have close to 500 patients. And actually, this was accepted for a poster presentation at ASH, and we're waiting on one more center with about 200 patients that will increase this cohort to close to 700 patients. But what I want to share with you is the data that we have so far. And interestingly, what we see here is that clinical factors were still the most important ones with relation to overall survival. And this is that hemoglobin less than 10 and platelets less than 50 at time of transplant. And with that, higher DIPSS were the factors that were predictive for worse overall survival after transplant, while high-risk mutations were not found to be predictive for transplant outcomes. So our conclusions so far are that clinical variables, and as I said, hemoglobin more than 10 and platelets more than 50 times of transplant were associated with improved overall survival. High-risk molecular mutation known as ASXL1, UTAF1, EZH2, IDH mutations were not associated, were not predictive for overall survival. Splenomegaly in this analysis was not associated with overall survival, but was associated, again, showed to be associated with worse engraftment or longer time to engraftment. And in this analysis, alternative donors were not associated with overall survival, which actually will bring me in a second to talk about the donors or the graft source. Another thing that I think we just heard a little bit about this now, and I'm sure you heard more about in the morning with relation to the disease, is how myelofibrosis is a disease that is associated with a very inflammatory milieu, and that actually has effect on transplant outcomes. So there are different cytokines that are upregulated with this disease and have been shown to be associated with a more aggressive phenotype of the disease. We have much interest in IL-8. Again, this is work that is being done at MSK in collaboration with Mount Sinai, led by some by Dr. Rampal and some by Dr. Hoffman, and show that increased IL-8 is associated with increased transfusion requirement, worse constitutional symptoms, and inferior survival with this disease. In a very small cohort of patients, or actually samples of patients that underwent transplant at Memorial Sloan Kettering, 17 samples, what we, or actually work that was done by one of my colleagues, Dr. Dunbar, what he showed is that in patients who underwent transplant and then had a disease relapse post-transplant, there was actually a signal early on after the transplant, within the first 3 months, of seeing that IL-8 and actually the CXCL8, which is the gene for IL-8, was upregulated early on after transplant. So with this very preliminary data, there's much interest to understand of what cytokines are involved early on post-transplant and can predict for survival and relapse after transplant. Also touching on that, there's, as I said, some attempts to intervene on the this inflammatory milieu around the time of transplant. And this was a study that recently completed accrual, where Jakafi that was given pre-transplant was continued during transplant and until 1 year post-transplant. This was interim analysis that was presented at the ASH meeting in 2021. And what you can see here is actually very promising results with overall survival of 77% at 1 year, with relatively low graft versus host disease, with 1 year chronic graft versus host disease of 14%. But I think that also what is very interesting is talking about this GRFS, which stands for graft versus host disease relapse-free survival. This is a composite outcome that not only is talking about survival, but also talking about survival without disease and without one of the most limiting and affecting quality of life after transplant, which is chronic graft versus host disease. So you can see here that the 1 year being alive and without chronic graft versus host disease was 65%. That probably also talks about how Jakafi is a drug that is approved for treating steroid refractory graft versus host disease. But I think that these results are very interesting, and the drug was well tolerated and did not really affect time to engraftment. So definitely a signal here for the reducing of inflammation around transplant with improving outcomes. Last, I want to talk about graft-related factors. So very interestingly, when we do, unfortunately, or myelofibrosis is overall a disease that we don't transplant in terms of numbers similarly to other diagnoses like leukemia. So for us to be able to gather information about patients with myelofibrosis under transplant, we usually need to go to the registry and look into cohorts that were collected over many years. But this is actually something that comes up again and again and again, that HLA matched donor related donors are the best donors for patients with myelofibrosis. So you can see here that when we look at different donors, when we use HLA match, that is a relative family member, the 1-year overall survival is 80%. When we use HLA match that is not from the family, match unrelated donor, this is going down to 70%. And when we go, and then we go to a haploidentical, which is a family member who is half a match, we're farther down to somewhere around 67%, and using a mismatch unrelated donor from the registry farther down. Now, whether there is really a biologic reason for that, one hypothesis would be that because myelofibrosis is such an inflammatory disease, when you add cells from someone who is genetically different, you actually increase the risk of graft versus host disease, and that can be probably the biological explanation for that. But I think it really is very important to understand, as I just spoke about it, we're looking at cohorts going back to now 13 years ago. And the way we did transplant in that context and the way we handled graft versus host disease is not the same way that we handle graft versus host disease now. Particularly these days when we use mismatch or haploidentical donors, we use a certain type of graft versus host disease treatment to prevent graft versus host disease with post-transplant chemotherapy called cyclophosphamide, as well as tacrolimus and mycophenolate. And I think that this really begs the question to do a study using also haploidentical donor and mismatch in the way that we do this these days with the prevention regimens that we use for graft versus host disease, because unfortunately, most of our patients with myelofibrosis, they are in their 6th and 7th decade of life, and even if they have a siblings who is HLA matched to them, it's going to be an older donor, and the data is very consistent that younger donors are associated with better transplant outcomes. And beyond that, not everyone has HLA matched donor in the family or out of the family. So we really need to study and understand why an HLA mismatched donor has worse outcomes, or can we overcome these poor outcomes with the way that we prevent graft versus host disease now. Now, I think that this is probably the most challenging and difficult question when we talk about transplant is timing of transplant in patients with myelofibrosis. So this was a large study, retrospective analysis, looking at transplant versus no transplant in patients with myelofibrosis. And the differences that you can see here is according to the disease stage, according to the DIPSS. And what this study showed is that for patients who has low-risk disease and intermediate one, these are the two on the upper part, doing transplant early is associated with worse survival. While for patients with more advanced disease, the DIPSS and the high-risk myelofibrosis, over time, transplant offers better outcomes. Now, why am I saying that this is the most challenging question, and how are we thinking about this now at MSKCC? So I actually really want to see every patient with myelofibrosis very early in the course. And the best thing that I can tell them is that you and I don't need to see each other in the near future. There are many studies in the field of myelofibrosis. Maybe we'll never need to see each other. But that doesn't mean that we do not need to follow you very, very closely, because that goes back to me, the point of really where we need to pull the trigger of transplant is where that hemoglobin starts dropping and when patients start to become transfusion dependent. I mean, hopefully not transfusion dependent, but we recognize that point where the disease starts changing behavior and they become more anemic, because we know that this really changes how the disease behaves. This is when we want to offer the intervention before we start seeing iron overload. But at the same time, I think that for people to hear that you may need this treatment, and this is a treatment that will affect your life quite significantly, at least in the early time post-transplant, it can be very challenging and very anxiety-provoking. So I still feel that this remains a very challenging for us as clinicians to tell someone, yes, you need this treatment and this is the only curative treatment, yet we don't need to do it necessarily now. But I think the data is very supportive of that we should not transplant patients at early stages of this disease. And with that, I would just like to show this picture because I think a picture is worth 1,000 words. So you can see how the bone marrow looks pre-transplant with significant amount of fibrosis versus bone marrow that looks well and grafted around day 100 post-transplant. This is the desired outcome. Many patients actually ask me, will the fibrosis go away? And this doesn't necessarily happen so early after transplant by day 100. Many times we can see ongoing fibrosis for even up to 6 months post-transplant and even up to a year after transplant. However, as long as we have evidence that the cells engrafted and we have normal counts, we understand that the new and healthy stem cells were able to overcome the very inflammatory milieu and the fibrosis in the bone marrow and give a normal and functioning blood system to the patient. And with that, I'm going to conclude. I don't know if I demystified transplant, but I'm happy to answer a question, whether now or later. And thank you.
Thank you, Dr. Tamari. This is a very important talk and, one to conclude the day for the plenary sessions.